abdominal surgical emergencies. Already you have had a wonderful lecture about some important topics. Here I would like to focus some more important topic when you are working at critical care unit or ICU. Here in this topic I would like to say something about pancreatitis and upper GI, lower GI bleeding, and third one intra-abdominal compartment syndrome. So three important things we are going to discuss in these lectures. Briefly as well as clearly we will see everything. So in this lecture main focus we are going to classify and severity of the pancreatitis, outline the management of pancreatitis and its complications, and explore the difference between upper GI, lower GI bleeding and diagnostic methods and management and compartment syndrome. So as usual we will discuss one case study for this. 58-year-old man with cirrhosis from chronic alcohol abuse presents to the emergency department with abdominal pain. Blood pressure 90/70, heart rate 150. Physical examination reveals distended abdomen, tender over the epigastrium. What are the possible diagnoses? About 1 hour later, the patient becomes more lethargic. So, with the pressure of 90/70, heart rate 115, and lethargy, so you should think about some serious conditions going on this patient. So, as a doctor, we don't have much time to think. Just immediately we need to act on these patients. We studied in our medical field, so whatever critical patients, as usual, we will start with ABC. That's a very basic thing. Airway, breathing, circulation. So you want to start with ABC. Even you can think the diagnosis later. So as usual, you start with ABC. Airway is okay, so you need to give sometime oxygen, sometime not necessary. Breathing part you should check, then circulation. As usual, circulation, what are things you will do? Wide bore cannula, take the blood for investigations, and IV fluids. These are the basic things you will do. I know you know everything, but just we are re-polishing these things. So you can see in this picture the slides, complete blood count, basic metabolic panels, arterial blood gas analysis. That's an important critical test. Abdominal radiograph, sometime you will do, that will be normal. Scan is very important. Previous speaker also mentioned this, very important for diagnosing some critical conditions. And as usual, if you know chronic alcoholic with this sort of epigastric pain, you may think about pancreatitis. So you definitely do the serum amylase or lipase. Normal alkaline phosphatase, normal transaminase, other values also here mentioned. Amylase and lipase gone up. Abdominal pelvis CT, that is usually not like a baseline test for this condition, but some complicated conditions, if you think some pancreatitis related complication, you will request the CT abdomen with contrast, pancreatic protocol. So you have ordered this thing, you got the results. So you know basic diagnosis of pancreatitis, you will check few criteria. Characteristic of abdominal pain, elevated amylase 3 times more than upper limit. Lipase also same. Imaging may reveal pancreatitis. Most common causes of pancreatitis, you study gallstones and alcohol. Here this patient obviously having chronic alcohol abuse, but additionally gallstone also possible, but usually these are the 2 important causes. Other than that, many medication, poisoning, envenomization, many other causes. Trauma, in a war, little baby with pancreatic injury because of cycle handle injury. So that sort of conditions possible. That also can aggravate the pancreatitis. But these are the two common causes. If you want to classify the pancreatitis, you can divide it into two. One is intestinal edematous pancreatitis, that is common and occurs approximately 80%. Mild disease, 2% mortality. So most of the time you can manage at ward level. So critical care point of view, this patient you will unlikely to see at ICU. But second part, necrotizing pancreatitis. You know that's a worse condition. Even it will give mortality approximately 30%, even though high medical treatment. 1/3 of the patient will die. So first one mild one, second one critically ill patient with necrotizing pancreatitis. So you know there are so many complications due to pancreatitis. Local complications, systemic complications, and organ failure also we need to consider. Local complication, as usual, edematous pancreatitis or necrotizing pancreatitis can cause fluid collection. Local edema can cause gastric outlet obstruction because you know the anatomy, pancreas is very close to the intestinal tract, so it can obstruct the lumen of the intestine. And portal vein thrombosis and colonic necrosis. So systemic complication, as usual, it can cause organ failure and worsen comorbid illness. Persistent organ failure more than 48 hours, defining features of severe acute pancreatitis. So the basic mind, you need to treat the patient to prevent the complications. We will discuss how. So these are the management principles. You know all the organs should receive adequate perfusion. If you take the head injury, you will maintain the blood pressure. Same thing here also, because if they lose the blood circulation properly, low volume, low pressure, that will affect the pancreas also. Not only other organs, pancreas also vulnerable for the blood circulation. So if they don't have adequate blood supply, they will get more injury. Enteral nutrition. So there are controversy. Earlier, usually we will think all pancreatitis patients should be keep nil by mouth. Nowadays, we are recommending we can start enteral feeding, enteral nutrition. And distinction between sterile and infective pancreatic necrosis is important. So all the pancreatitis, we don't want to start the IV antibiotics or oral antibiotics. Prophylactic antibiotic usage is not good. Only we will give the antibiotics for the infective necrotic pancreatitis. So until that, you don't want to start any antibiotics. Previously, sometimes we will use the antibiotics like prophylaxis, but that is not recommended. So we don't want to start antibiotic unless infection. Then complications when we consider continuously venous injuries, because you know pancreas is close proximity to some other venous structures that can cause thrombosis due to localized inflammation, and arterial eruption aneurysm possible, that also can cause arterial hemorrhage. And you know the recurrent attacks, because the alcoholics and recurrent gallstone disease patient, they may get recurrent attacks. Sometimes pancreatic necrosis possible with a recurrent attack. So these are the things you need to consider. So when we see this patient, so we already seen the patient, he's a chronic alcohol abused person, present with epigastric pain, low blood pressure, high pulse rate. So this patient, already you know the history, he is staying 3 days in the ward or ICU. Maroon color fluid noted from the NG tube. As usual, sometimes we are keeping NG tube for the pancreatitis. That will help for empty sometimes fluids, sometimes will help to give some enteral feeding. But the nurses said the particular NG tube fluids are maroon color. Blood pressure 84/62, heart rate gone up 125. We will ask some brilliant people to answer. What do you think? Why this maroon color? Louder. Any idea? Always not think about pancreatitis. Other than that, also some other causes can cause macular bleeding. Ruptured esophageal varices. Good. So one thing, some upper GI bleeding. Upper GI bleeding possible. Not only ruptured esophageal varices, even some ulceration in the stomach also can cause bleeding. So we will go into that partly. So we are going to discuss some upper GI bleeding. So we will see. So we are going to discuss about differential diagnosis as well as management types. So first we will discuss about the management. Before that I will discuss a little bit. One is varices, second one gastritis, because patient is in ICU care. Usually you know ICU patients, they will get stress ulcers, so they can get bleeding. And you can divide it into two groups. I will discuss one by one. So you need to think about other conditions also, not only pancreatitis, there may be other causes. Okay. So as usual, this patient is again, so he may stable for 3 days. Again he is deteriorating. When he is deteriorating, you may need to think about causes. One is you are going to assess a vital sign. Again, examination of the abdomen and rectal examination. Rectal examination very important because patient may have black color or tar color stool. That indicates upper GI bleeding. And laboratory test you need to do, especially coagulative profile and NG tube already there. If not, you need to place. Endoscopy, angiography you can do. So you can divide it into two groups. One is non-variceal upper GI bleeding. Second one is variceal upper GI bleeding. Non-variceal, variceal. So that means non-variceal means that patient is not having esophageal varices, but even though they are having bleeding. Other group, they may have obvious varices. That varices can bleed. So two groups. When you see 80 to 90% non-variceal bleeding. Among the 80 to 90%, 40% due to peptic ulcer. Maybe from stomach or maybe from duodenum. Peptic ulcer. Another 5 to 10-15% may be due to excessive vomiting due to malarious TN. So two things are important. One is you need to divide non-variceal bleeding. Majority are non-variceal bleeding, 80 to 90%. Another 10-15-20% due to esophageal varices. Among them, peptic ulcers are common. So this patient may have one of these, maybe variceal, maybe non-variceal. So again, I said variceal bleeding again due to cirrhosis. Right, easy way. How can you differentiate both? Easy way. Very easy, you can do it. Variceal bleeding or non-variceal bleeding. How can we differentiate? One volunteer. Simple question, very simple question. Maybe third year medical student question. Variceal bleeding or non-variceal bleeding. How can you differentiate? I don't want to ask the experts, I just want to ask the academics. Boy with specs? Louder. Esophageal varices, that is the internal structure. You can visualize easily. How you can visualize? Yes, you are correct. Upper GI endoscopy. When you put the scope, you can see the obvious varices is there or not. Is there any bleeding point? Suppose without varices also they have some bleeding points. So you can easily see. And you can do some intervention also. With the upper GI endoscopy, you can do intervention. So that's a very simple answer. Okay. So non-variceal bleeding, usually medically you can manage because you know the ulcer causing bleeding. Gastric ulcer, peptic ulcer. What may be the treatment? Answer also there. Proton pump inhibitors. You can use omeprazole, you can use pantoprazole, infusions. Usually these infusions are quick action. You can give because patient is having vomiting, patient is not tolerating the oral. So you can use IV, simple IV infusion. So they have recommended these proton pump inhibitors you can use. Other than that, so many medications we are using. According to this presentation, we will optimize the patient with proton pump inhibitor. How it's working? One is inactivate pepsin, optimize platelets function and inhibit fibrinolysis. So actually the clot should be there, then only the bleeding will arrest. The raw area should be covered with something. Even you may have sometimes supralpha and other things you can use. Suppose this patient is having variceal bleeding. Esophageal varices is there, variceal bleeding. So varices means some dilated venous structure. How you can treat? You need to constrict that vein. So you need to give some vasoconstriction. You can inject around the vein. You studied some vasoconstriction, whatever you can inject. Reduce portal venous pressure flow. And these are the things, and antibiotics helpful in these conditions. They recommended third generation or second generation cephalosporins. That is showing some reduced mortality. So upper GI bleeding specific diagnosis 95% with the endoscopy. 25 to 35% requires therapeutic intervention. Mainstay of variceal bleeding, sclerotrophy or banding ligation. You have seen when you visit our endoscopy units, we are giving sclerotrophy or banding. Temporarily we will give some vasoconstricting injections also. So sometimes some advanced therapy, if we have, we can utilize angiography with embolization, balloon tamponade and surgeries. Whatever you are doing, everything failed, you may need to do surgical control. That's a final result. But balloon tamponade, high risk of rebleeding and esophageal rupture, but because you are giving high pressure. When you release the balloon, again sometimes they will bleed. Okay. Angiography is a good thing. Approximately 90% you can achieve. You may heard this procedure. Transjugular intrahepatic portosystemic shunt. This is for high portal pressure patients with recurrent bleeding, recurrent varices you can use. One complication and encephalopathy will come because you are going to bypass the circulation without going to the liver. Another important thing, lower GI bleeding. Approximately 80% from upper GI, 20% from lower GI. Again, you already studied about diverticular disease and complications, and one of the complications of this diverticular disease is bleeding. So diverticulum can erode the vessels, they can bleed. Angiectasia, intestinal ischemia related bleeding, neoplasm, inflammatory bowel disease. There are so many causes. Other than that, pediatric we have polyps and other things also. Mild bleeding due to fissure possible, but these are torrential bleeding. Patient may bleed and die, that because of massive bleeding. Anal fissure never bleed and die, that sort of massive bleeding will not happen. But here this bleeding can kill the patients. So you may need to know how to investigate and how to manage. As usual, investigations After basic investigation, coagulation profile, basic things, you may need to do the radiographic diagnosis. You may heard about radionuclide scan. That's technician 99 scan. Very useful. Even minor bleeding you can diagnose. That is the isotope. You can inject and you can do the imaging with the special techniques. So even 0.05, it's a very tiny bleeding per minute, also can even diagnose. If not, you can do other things, CT angiography, CT enterography. Angiography can detect approximately 1 mil per minute. So lower GA endoscopy also very useful. If patient is okay, stable, you can take and do the endoscopy. Approximately 90% you can diagnose. There are other techniques, push endoscopy, video capsular endoscopy. Currently we don't have much, but these are the new techniques. Some hospitals they have video endoscopy capsules. We will ask to swallow the capsules. Capsule will have camera, so it will record all the directions. They have camera. When you ask to swallow the pills like a capsule, that will travel along the GA tract. Same time you can visualize this. They will transmit like a Wi-Fi or Bluetooth or whatever techniques. You can get the image, real image in your recorder. So if there is any bleeding point, exactly you can spot it and you can take some action. But disadvantage, you cannot intervene with the capsule. Capsule will just like a camera. Like endoscopy is not like that. You can do some procedure with endoscopy. Depending on the cause of the bleeding, you may need to do some intervention. One is interventional radiologist support. You can do some embolization of the vessels. Endoscopically, you can do clips, coagulation, now banding, injection of epinephrine, and you can tattoo the point. When you do future surgery, you can tattoo the point exactly with the endoscopy. So when you go into the laparoscopically open surgery, you can see the tattooed bowel separating, and particular area you can resect. Even tiny malignancy, tiny lesions, you may need to tattoo. Same patient with your aggressive resuscitation and upper GA endoscopy, non-variceal GA bleeding was controlled and he was stabilized and started on pantoprazole infusion. Next day he becomes oliguric with elevated peak airway pressure. Same patient, so you have tried to control all these bleeding, everything. First you have treated for pancreatitis. Second thing you have treated for the what condition? For GA bleeding. Third one, he is not passing urine. His respiration also difficult. Here, well-known anesthesia team people are there. They know how to manage the anesthesia part, the actually airway breathing. So you know this patient is now having another two important new issues. One is oliguria due to renal shutdown. Second thing, respiratory compromise due to pushing of his diaphragm upwards due to increased intra-abdominal pressure. Right. So you may ask, what do you mean intra-abdominal hypertension? For medical definition, hypertension, there are some value. But here, intra-abdominal hypertension, more than 12 millimeter pressure. So you need to measure the pressure. Then only you can talk about hypertension with the epidermis. But clinically, there are so many features. But if you want to exactly tell, there should be more than 12. You can place the Foley catheter, like a urinary catheter, you are putting, and you are making some water column, and you are just measuring with this pressure. Outside you can measure. So that will indirectly mimic the intra-abdominal pressure, because the urinary bladder is inside the abdominal cavity. So you can measure with that. So one of the way. Intra-abdominal hypertension is one of the alarming feature. You may think this patient is going to have some issues, but Another important serious condition is intra-abdominal compartment syndrome. That means compartment syndrome. That is a worst condition. You see the pressure's gone up. Now 20. Earlier I said 12. Here 20. 20 for adults actually. Pediatric 20 is too much. So more than 10 is also considered compartment syndrome. You know, when I am doing laparoscopic surgeries, I usually maintain the pressure 8 or maximum 12, not like adult. Because these babies and kids, we need to keep the pressure very low. Because, right. Then, with these, they should have some features of organ failure. Intra-abdominal organ or other organ related compromise conditions should be there. There are 3 types you can talk. One is primary, that means some conditions due to intra-abdominal pathology. Secondary due to outside. Third one is recurrent. Primary means you see the peritonitis, perforation can cause these sort of compartment syndrome or intestinal obstruction. But secondary, you know, you have studied already external causes like a burn injury. Circumferential burn injury can cause constriction of the abdominal wall muscles. That means compliance of the muscles wall. So that particular condition can cause secondary abdominal compartment syndrome. And sometimes we are putting some tight bandage dressing due to some burn or some conditions that may cause. Third one, recurrent. So mainly clinical manifestations, they can compromise the blood circulation. You know, the venous circulation is very low pressure, it will immediately compromise by these sort of compartment syndrome. Gastrointestinal compromise can cause mesenteric ischemia, bacterial translocation, lactic acidosis. Renal compromise can cause all these complications like oliguria and renal injury, acute kidney injury. Cardiovascular, you know, venous return compromised, so preload will compromise automatically, afterload also compromised. Preload compromised, cardiac output will compromise. Respiration, we discussed, because of increased intra-abdominal pressure can push the diaphragm upwards. So diaphragm function completely shut down with this sort of high pressure. CNS, again venous return, can cause hypovolemia, hypotension. Right, so you know, intra-abdominal hypertension can cause massive consequences, especially organ damage and these sort of inflammations. So as we know, wherever compartment syndrome, it should be released early, because otherwise ischemia can cause many problems. Any questions up to now? I know, I observe you never ask any questions previously also. I hope you will not ask any questions. 2 reasons if you are not asking question. 100% understood, or other one 0% understood. We assume positive. So you know, we have studied about some important factor. One critical patient with epigastric pain present to you with suspected pancreatitis. You have done the basic investigations. You have resuscitated the patient first, and pain management is important. So always pancreatitis patient, consider the pain management, nutrition, hydration, as well as gut rest. Gut rest, you can start the feeding early, but don't overload the pancreas. Don't give too much of work for the pancreas. Same time, if you suspect any infection, only start the IV antibiotic. Otherwise, don't give antibiotics. That's the important thing. Pain management is very important. Second thing, if the patient develops complications, you need to treat the complications. Maybe one of the complications may be stress ulcer. Gut ulcer is there. So you are starting in investigating with the endoscopy. You can spot the lesions. You can start the IV proton pump inhibitors. Example, omeprazole, pantoprazole. These are the conditions you have managed. And third thing, Suppose the patient is developing some complication due to pancreatitis. Pancreatitis itself can cause even intra-abdominal compartment syndrome. So you need to manage that part. Mainly intra-abdominal compartment syndrome, depending on the cause, you need to act. Sometimes you are using muscle relaxant or something to give some external compression, like a burn something. Otherwise, scarotomy, we will do the scarotomy. That means we can cut the scar and we can make the abdominal wall compliant. But these sort of special pseudocyst structure, something peritonitis, you may need to have different approach. You can monitor with the Foley skeleton, that also not direct method. Indirectly you are going to measure that and you are going to manage. So always keep the blood pressure in a standard level. Then only you can maintain the perfusion. Okay. And in septic condition, you can use the antibiotics. I hope so. Some take-home messages for you. Routinely, don't give antibiotic for pancreatitis. Oral feeding, whenever possible, you can start. And upper GI treatment, mainly you can control or you can manage with the medical treatment without much intervention, because the 80% of them are non-variceal bleeding. So due to some ulcer or something, you can manage. And lower GI bleeding, localization, and depending on the outcome, depending on the diagnosis, you are going to manage. Intra-abdominal pressure, you can indirectly measure by bladder pressure. And early treatment is important for intra-abdominal hypertension and compartment syndrome. Decompressive laparotomy is useful for some conditions. Hopefully everything fine. Thank you.